Welcome back to another masterclass. This is Dr. Naveed Ul Zafar, clinical physiotherapist. If you caught part 1 of this series, you will remember a runner whose Achilles pain wasn't just overuse and a cardiac rehab patient whose heart rate wouldn't cooperate. Both cases where the medication list changed everything. If you missed it, go watch it first. Link is in the description. Today builds on the same idea. Actually, remember right at the start of part 1, I mentioned a couple of other drug classes we'd get to eventually. Today is the day we finally cover them as full cases. 2 more cases, both routine looking on the surface, same as before. Case 1, a patient sent to you for straightforward deconditioning, except something about her presentation doesn't quite add up. Case 2, a patient who bruises far more than he should after a completely routine treatment session. Is it your technique or something else? Let's get into it. Quick reminder before we dive in, and this one applies to both cases today. Medications can affect your patient in 2 big ways that matter to you as a physiotherapist. Sometimes they change the tissue itself, how strong it is, how it holds up under load, and sometimes the tissue is fine, but the drug changes how your patient's body responds to what you actually do to them in treatment. Keep both possibilities open as we go. Don't assume which one you are dealing with until the case tells you. Let's begin. A 61-year-old female is referred to PT for deconditioning and bilateral thigh pain. She started a walking program 3 weeks ago and high-dose Atorvastatin 6 weeks ago. She now has symmetric proximal thigh and hip pain with new difficulty rising from a chair and climbing stairs. No trauma. Mild symmetric weakness in hip flexors and extensors, no focal neurodeficits. What is your next step? Option A, progress walking, add resistance training. Option B, reassure her, normal post-exercise soreness. Option C, refer for bilateral hip MRI. Option D, hold exercise, refer for CK and meds review. Alright, pause it here. If you want to work through it yourself, I will wait. Okay, let's break it down. Option A, progressing her walking program and adding resistance training. I get why you would pick this. The referral literally says deconditioning, so a fresh graduate sees that word and jumps straight to progressive exercise prescription. But look closer. This is bilateral, symmetric, proximal, and it lines up almost exactly with when her statin dose went up. Loading muscle that's already struggling isn't the answer here. It can make things worse. Option B, reassuring her that it's normal post-exercise soreness. Tempting because she did just start a walking program and new exercise can absolutely cause some soreness. But normal soreness, that is DOMS, peaks within a couple of days and fades. This has been building for weeks. It's affecting her ability to get out of a chair and climb stairs. And it's symmetric on both sides. That is not a typical soreness pattern. Something else is going on. Option C, referring immediately for a bilateral hip MRI. This feels through and I understand the instinct, but an MRI isn't going to tell you what's actually happening at the muscle cell level here. It's not a structural problem. Ordering imaging when the clinical picture is pointing somewhere else entirely just delays getting her the right workup. Option D, this is your answer. Here's why. You recognize this as a possible statin-induced myopathy. Here's the concept and I will keep it simple. Statins block an enzyme your liver uses to make cholesterol, but that same pathway also produces a compound called CoQ10 which your muscle cells rely on for energy production. Block it hard enough and some patients develop this exact pattern: symmetric, proximal muscle pain and weakness, functional difficulty with things like stairs and chair transfers, time to starting or increasing the dose. Rarely this can progress to something more serious, actual muscle breakdown, which is why you don't want to be the one pushing her harder through it. So what do you actually do? You hold the exercise progression for now. Don't add load. Don't push through the deconditioning plan as written. You refer her back to her physician for a CK level, which is the blood marker that tells you how much muscle breakdown is actually happening, and for a medication review. If it is the statin, her physician may adjust the dose or switch medications and her symptoms often improve. Once that's sorted, you can safely build her exercise program back up and don't just assume every referral label is accurate. Deconditioning was the reason on the referral. Your job is still to examine and reason through what's actually in front of you. So, your takeaways: number 1. Statins can cause a spectrum of muscle problems from mild myalgia to true myopathy with elevated CK to rarely serious muscle breakdown. Number 2. The classic pattern is symmetric, proximal muscle pain and weakness, hips, thighs, sometimes shoulders, not a one-sided localized injury. Number 3. If symptoms start or worsen after a new or increased statin dose, don't file it away as ordinary exercise soreness. Number 4. Hold aggressive loading and refer back for CK levels and medication review before pushing exercise progression forward. Alright, that's case 1. Now different drug class, different tissue entirely. This time it's not about muscle, it's about how your hands on treatment interacts with the patient's blood. Let's go. A 70-year-old male with atrial fibrillation on Apixaban is referred to PT for thoracic stiffness. After session 1, moderate pressure soft tissue work on his upper back. He returns with a large area of bruising over the treated region, no increased pain, no neuro symptoms, no expanding swelling. What is your next step? Option A. Continue the same grade 4 deep tissue plan. Option B. Stop manual therapy, switch to exercise only. Option C. Refer to physician before continuing. Option D. Continue with lighter grades, no deep tissue. Same as before, pause this video and think of the right answer. Alright, let's break it down. Option A. Continuing the same grade 4 mobilization and deep tissue plan. Tempting because there is no expanding hematoma, no neuro symptoms. He tolerated it technically, but that bruising is your warning sign. He is on Apixaban. His clotting is intentionally suppressed. The same pressure that would leave a small mark on someone with normal clotting just left a large one on him. Keep applying that same intensity and you are ignoring what his body is telling you. Option B. Stopping all manual therapy permanently and switching to exercise only. I understand the instinct. He bled more than expected, so maybe hands-on treatment should be off the table entirely, but that is an overcorrection. Being on an anticoagulant doesn't mean manual therapy is off limits. It means you grade it appropriately. Cutting out a legitimate treatment tool for good when a modification would work fine isn't good reasoning either. Option C. Referring him back to his physician before touching him again feels responsible, but look at what actually happened. Some increased bruising, no expanding hematoma, no neuro symptoms, no excessive pain. That is a non-expected response in a patient on blood thinners. It doesn't need physician clearance before every session going forward. Save the referral for something genuinely concerning. Option D. This is correct. Let me explain why. His medication changes how his body responds to mechanical pressure, not whether he can be treated hands-on at all. Apixaban interferes with the clotting cascade, so his body can't quickly seal off the small capillary damage that routine soft tissue work naturally causes. That is exactly why even moderate pressure showed up as a bigger bruise than you'd normally expect. So, what do you actually do? You don't abandon manual therapy and you don't ignore what happened either. You drop your mobilization grades, think grade 1 or 2 instead of jumping to grade 4 and skip the deep tissue work for now. Keep him in your plan but with intensity that respects his current bleeding risk and you know exactly what to watch for going forward. An expanding bruise, a firm or swollen area that could be a hematoma, increasing pain or any neurological symptoms nearby. Those are your signal to stop and refer. Ordinary bruising that stays stable is not. Your takeaways: number 1. Anticoagulants, whether it's warfarin or a DOAC like Apixaban or Atorvastatin, increase bleeding and bruising risk with manual therapy. That is not a reason to avoid hands-on treatment. It's a reason to grade it down. Number 2. Drop your mobilization grades and avoid deep, aggressive, soft tissue work in anticoagulated patients, especially early in treatment. Number 3. Watch for the rear red flags: an expanding bruise, a firm or swollen area, increasing pain, or neurological symptoms. Number 4. Ordinary, stable bruising after treatment is an expected finding in this population. It's a cue to modify your technique, not necessarily to stop treatment altogether. Case 1. Muscle pain that looked like a simple deconditioning soreness but was actually a statin interfering with how her muscle cells produce energy. Case 2. Bruising that looked alarming on the surface but was really just his blood thinner doing exactly what it's designed to do and a sign to modify your technique, not abandon it. That is 4 drug-PT interactions covered now across this series: fluoroquinolones and tendons, beta blockers and heart rate, statins and muscle pain, anticoagulants and manual therapy. The lesson doesn't change. The medication list isn't paperwork. It's part of your exam. Comment below which of these 4 would you have missed as a new graduate. Be honest. If this helped you, subscribe, hit the bell and share it with a colleague. I am Dr. Naveed Ul Zafar. See you in the next one.